Okay, it's started.
And tonight is our Zoom meeting for the IABDM, and we are going to talk about myofunctional disorders, and we actually have a team that is going to be speaking to us. This is critical for those of you that do oral airway. It's also an option if a hygienist wanted to get further educated as far as getting into something different besides wet finger dentistry. You want to retire, you don't want to be around aerosols anymore. This would be a perfect occupation. But I don't want to take jobs away from Sue and Andrea. I'm going to turn it over to them, and let's everybody mute ourselves except for them so that we can hear. Y'all take it away.
Okay, just want to make sure everybody can hear me. All is well? Okay, great. Hello, everyone. Thank you for joining tonight. My name is Sue Merino, and I work at Orofacial TX with Andrea Butler. We are both certified speech-language pathologists. I'm a certified orofacial myologist. Andrea is actually a certified lactation counselor. And we work here in the Woodlands, Texas, and by like Technology Boulevard, Technology Forest Place. And today we're going to present to you regarding what orofacial myology is and talk about orofacial myofunctional disorders, which I know is quite a mouthful. And we'll talk about tethered oral tissues. So the learning objectives for today are to understand what it is, where it comes from, what they look like, these myofunctional disorders, making the decisions for your patients on when to refer, and also talking about the importance of the multidisciplinary team when it comes to myofunctional disorders. And I just want you to constantly and always think about breathing. That's going to be driven home well during this presentation. Okay, so a little bit about me. I've been a speech therapist for over 20 years, and again, I've been certified as an orofacial myologist by the International Association of Orofacial Myology. My niche is working with oral stage swallowing, orofacial myofunctional disorders, habit elimination, and feeding. Developmental speech and language disorders, and any kind of family education support. Andrea Butler also has 20 years of experience as a speech-language pathologist. She has experience with working in the schools, just like myself, and she's an orofacial myofunctional therapist. She's a certified lactation counselor, so she sees our babies, and has a interest in the feeding aversions, oral stage swallowing, habit elimination, and orofacial myofunctional disorders as well. Okay, so one thing about this, I'm going to have to, okay, so what is orofacial myology? It's orofacial myofunctional disorders are atypical and adaptive patterns that emerge in the absence of normalized patterns within the orofacial complex. The regular presence of these adaptive movements can often result in a variety of disturbances. So we will this is Linda D'Onofrio. She is well known in the world of oral dysfunction and in orofacial myofunctional disorders. So what she basically says is that most infants are born with a normal craniofacial shape, normal jaws, normal airway. Their alveolar process easily accommodates their tongue and their future teeth. And orthodontists see multitudes of children with abnormal jaw relationship. And they'll see that steep mandibular angle, anterior open bites, high narrow palates, posterior cross bites. And why are all these kids needing to see orthodontists when they started off just fine? And most orthodontists want to see patients after they're 8 years of age, but a lot has happened before that time to get them to the point of the orthodontist chair. And the facial dysmorphology is often, evident earlier than that age 8. So when oral dysfunction goes untreated, an orofacial myofunctional disorder can result. So first we form the habits and then they form us. Muscle wins over bone every time. So conquer your bad habits or they'll eventually conquer you. When muscle is performing abnormally, that's where we come in, where the purpose of therapy is to affect the changes in the behavior that reach and to get them to an automatic level. So we are going to work with patients in terms of their tongue resting placement, their muscle use in terms of their lips, tongue, cheeks, and jaws. And we're going to help eliminate any of those oral habits that may be an issue and causing any kind of issues with their dentition, their swallowing, their speech, their sleep. We're going to go through all of that. So let's talk about oral habits. What are those? Those are the people that are clenching or bracing. So they're kind of, they are basically chewing on their tongue, and I can show you pictures of that later. People that suck on their tongue, people who bite their nails, people who bite on pens and pencils or lean on their hands a lot or lick their lips often. I'm sure you're thinking of lots of people in your world that may have some of these habits. And if you do, everything is frequency and duration. So if you do something for too much and too long, then it will have effects on your craniofacial system. So I'm so sorry, I just noticed that this is turned and I meant to turn that before we spoke today, but if you can just tilt your head, sorry about that. So here's a picture of a child who was a finger sucker, and you can see how it created that anterior open bite. So 13 areas of oral function that impact occlusion. Breastfeeding, and I'll have Andrea talk about that a little bit more. And soft tissue airway obstruction. There's some soft tissue restrictions in terms of tethered oral tissues, which we'll talk about more here in a little bit. Early feeding experiences, mouth breathing. We're going to talk about all of this. Oral resting postures, oral habits, which we just spoke of, swallowing concerns, chewing concerns, clenching and grinding concerns, oral dysfunction over time. There's some evidence to support that there may be some oral dysfunction that is happening in fetuses even before, so like babies that are thumb sucking in the womb before they've even arrived on the scene, and how that is affecting their palate even before they get to us. And then congenital facial dysmorphologies. So who experiences these orofacial myofunctional disorders? All ages, from birth to 100. And that's honestly what we see in our practice. We work with little babies all the way up to patients that are in their 70s and 80s. And newborns, infants, and toddlers. So here's a picture of a baby who was tongue-tied and lip-tied and having a lot of problems with chewing. So with swallowing, with their suck, swallow, breathe sequence. Preschoolers who were swallowing often the wrong way and therefore affecting their dentition. You can see those little open bites right there. Or toddlers that have, when you see the word TOTS in any of this, in any of these slides, it means tethered oral tissues. And they're constantly mouth breathing. And I know you've seen toddlers with those dry, chapped lips because they are mouth breathing. And they may be bruxing, which another word for that is basically grinding their teeth at night because they're fighting their airway. School-age children may have issues. So you can see that doesn't look exactly like a normal swallow technique that this child is trying to, as they're trying to just chew their food and swallow it down. You can see how those lips are pursing. And I think this child was given at first a habit appliance to see if that would stop them from swallowing a certain way, and it didn't really work. A tongue crib, I think, was put in. And there are orthodontists out there that'll put cribs in these patients because they see a tongue thrust. They're concerned about a child's how the tongue thrust is affecting their dentition. And then what happens is that once that gets taken away, the thrusting comes right back. So I'm not a big fan of those. I think that there are alternate ways to handle through therapy to teach a child how to swallow appropriately, or an adult. And then you can see, I know you've seen this look too in any of our elderly population with that mouth breathing. So why is this important? It's important because I want you to, at the end of this, be able to educate the parents that you're working with better to help their children. I want you to be able to educate your patients that are adults that are having some of their health issues that could be eliminated if they were to have better appropriate behaviors and patterns. I want you to help them know where to go if they need to eliminate any of those noxious oral habits. And I want you to understand that some of these conditions that you may see your patients have, such as apnea, bruxism, ADHD, all that may be a part of that may be because of some breathing concerns that your patient may be having, and their breathing, their airway should be looked at, and their overall cosmetic appearance. So diagnosis can be life-changing, and I want to just go through this a little bit. I even have some better slides on this, but the more, again, back to frequency and duration. So if you're not breathing well, then it's going to affect the way your facial shape develops, and craniofacial development is so important throughout the lifespan and to keep you healthy, safe, and strong. All right, so we're gonna break this down into different parts here. We're gonna look at respiration, so breathing, like I've talked about a couple times, and we're gonna look at posture, why that's important. We'll look at jaws and lips, tongue, cheeks, and then we're gonna talk about swallowing and speech. So let's talk about this one. Let's talk about what's normal first, because I think that's important before we talk about abnormal. So they say that Angelina Jolie is one of the most beautiful and most symmetrical people in the world. And the reason why is if you look at her facial shape, there's no tension. And there are some things about her that are just super impressive as in terms of her symmetry. So we all should be the width of 5 eyes. So if you were to take the width of this eye and go from your ear to your eye, then this should be wide. So obviously you can tell I'm narrow. Eye here and eye here. There are no abnormal forces that you can see. She has proper aligned teeth. Her eyebrows are aligned, her eyes are aligned, her nose is symmetrical, her lips are symmetrical. But we don't normally see that. We usually see some abnormal going on. And I want you to just look at this patient right here, just to kind of get a feel for what I mean. Have you ever seen patients in your office where their coloring just doesn't look quite right, like the kiddo on the left? That open mouth posture, that runny nose. If I could lift this bar up a little bit, you'd see that he has got some circles under his eyes. And the goal is that we want to get that kiddo through therapy to look more like, and it is the same kiddo, but on the right. So looking like he's breathing better, his lips are closed, the color, his whole face coloring looks better, just looks a lot healthier. So the red flags that I want you to kind of keep up with when you're looking at your patients, and this is all obviously very research-based, is concerns would be when you see patients that have open or pursed lips or dry lips, you see that low tongue forward position, you see that short upper lip with a reduced function and a pretty, like a bigger lower lip. You would see that they just have that low tone look to their whole facial musculature. Usually they have longer face. a forward head posture because they're fighting their airway and therefore they're leaning more forward to open up their airway. They also could have a tongue tie, which could also be affecting their posture, and we'll talk about that here in a little bit. Sometimes they'll have facial retrusion. A lot of times their bottom jaw will be retruded. Primary teeth are crowding, and upper incisor proclination. And then they would, if a child, let's say, or an adult were to happen to have a tongue tie and couldn't reach back and remove food from the posterior dentition, then cavities would be likely. So it's an iceberg effect. And I know I've mentioned the word breathing so many times, but it's true. Breathing is the #1 concern. So if we don't have breathing down, if we don't have a good airway down, then everything else is just going to follow suit. So that is the primary piece that we're looking at, and we test during our evaluations, and then we work on throughout therapy. And then from there, we're obviously using our help with any type of body worker, such as a craniosacral therapist or a physical therapist or a chiropractor, to any of those types of practitioners to kind of help us along with posture. And then we're obviously working on in therapy the sucking, swallowing, chewing. And at the very last, really, I mean, speech is kind of at the end when I have all the muscles better. That's when I can work on speech and just be a lot more successful and feel like my patients move along a lot faster. I get them in and out of speech therapy so much faster by working on this approach of this oral motor approach and this breathing approach. So this is an interesting slide in that this child it's the same kid. So this is the child on the left was 6 years of age, and on the right, she is 9 years of age. And the only difference is that she was given a hamster, and the hamster was in her room. And she was allergic to the hamster. And she just kind of dealt with it. And you can see the changes in her facial structure because of it. You can see the difference in her nose. You can see the difference in her lips. You can see the difference in her teeth. You can see how her face became a lot more elongated. And that was all because of an upper airway obstruction. So nasal breathing is optimal. You really want those nares to be open wide, have a gentle wave pattern through the turbinates. 8 to 12 breaths per minute is what is recommended. So when we test our patients, we'll test how many times they do a breath in and out for a 15-second span. And then we just multiply that by 4, and we get a good feel for how many breaths per minute a patient is typically doing at rest. And 1 breath every 6 seconds is what was optimal. And we're going to go in the next slide talking about these nasal turbinates and what they do to warm and filter the air. And there's oxygen and carbon dioxide exchange in those nasal turbinates. And there's a ton of nitric oxide, which we're going to talk about here in a second, that builds up in the sinuses. That's the biggest part of the body that holds that nitric oxide that's so important for us, that you only get with nasal breathing. And that nasal cavity traps the irritants and pollutants and provides moisture to prepare the air for the lungs. And it's optimal for craniofacial growth. So here's a picture I'd like to talk about. So what happens is that you breathe in through your nose, it goes through those turbinates, which honestly act like turbines, taking that air and filtering it, moistening it, warming it, sending it down to your lungs. The goal being that it gets down to your lungs at 98.6. The reason why it was able to do all of that is because, like I had mentioned before, nitric oxide is the molecule that is sent off by your body to do so. And that is the only time that nitric oxide will help us is when we are nasal breathing. You don't get it if you're mouth breathing, and therefore nasal breathing is best. So what would cause issues with, why would someone not be able to nasal breathe? Well, for every point increase in tonsillar size, the odds ratio of obstructive sleep apnea increased by more than 2-fold. So look at this, and those are what we would consider to be grade 4 tonsils right there. Those tonsils are touching the uvula in the back of the throat, and therefore cutting off optimal air supply throughout the body. We use some scales to look at grading of the tonsils, and this is a pretty common scale most people use. So a 1, 0 would be they're out, like, you know, the tonsils and adenoids maybe, but at least the tonsils were taken out from an ear, nose, and throat doctor. A 1 would be 25% airway obstruction. 2, it's about halfway there. 3, 3/4 of the way to the uvula. And then 4+ would be they're pretty much overtaking that airway. We also use something called a Mallampati score when we're doing evaluations. So we have the patient open up their mouth, and we're trying to see how well we can see that back palate. We're trying to see, again, if the tongue is laying pretty flat, that's a class 1. And then if you were to open up and look inside a patient's mouth and you can't see anything back there, you can't even see the uvula, it's just completely blocked, it's a class 4. I would say that the class 3s and class 4s always concern me, that there may be some sleep apnea type concerns, or at least some sort of sleep disorder breathing concerns. And those, so those questions need to be asked by your patient if you see that. So if the mouth is open, then because you have to breathe, because there may be some obstruction in the upper airway because of allergies, or like we just talked about before, the tonsils and adenoids are large, you have to breathe. So you have to do what you need to do to get the air. So your mouth's going to open, your tongue will drop low in the mouth following the mandible. The tongue can no longer provide any support for that upper jaw and for your palate, and therefore a reduced upper arch size results. The pH of the saliva elevates, causing cavity, the possibilities of cavities to increase. And a short upper lip with reduced function would probably occur with dried, cracked lips. Andrea, do you have anything else you wanted to talk about right there?
Not on that one, I don't think.
Okay, okay, just pop in whenever you want to interrupt me. So here's some research-based findings for patients that have that are oral breathing instead of nasal breathing. Typically, their gingivitis is greater. The chances of having a posterior crossbite, open bite, or a large overjet is greater. Those are those patients that have those dark eye circles, which is just pooling under the eyes because of a poor oxygen carbon dioxide exchange. Is poor venous pooling is what that is. And then nasal congestion and drooling, halitosis, which is another word for bad breath, hyponasal speech, so that sounds more like they're really stuffed up, like when we have a cold, and then alternations of muscle activity for speaking, chewing, and swallowing. So here's some research just saying that with an open mouth posture, you're going to get a narrowing of the maxilla and reduced development of the mandible. It'll significantly narrow the retropalatal and retroglossal areas and lengthen the pharynx. Dental arches will narrow. Cross bites will be common. They're more common in children that snore than children who do not. So here's some, if you don't know what like open bites look like or overjets look like, I just wanted to kind of point that out. So you can see these on the left side, you can see the spaces between the patient's lateral incisors right there. And that would remind you of a patient that is probably doing an anterior tongue thrust while they are swallowing, because they may have a tongue tie, or there's just such a narrowing there that there's just no, they don't have adequate space, and therefore when they swallow, that tongue will just pop through those holes, and those spaces will just stay there unless we fix that swallow. So a lot of times orthodontists will send their patients to us that are trying to do orthodontic work because they are concerned that if they go ahead and they close those open bites, that those open bites will come right back if they don't go through some orofacial myofunctional therapy. The other would be this a big overjet. So again, that patient is probably tongue thrusting as well, but presenting in a different way because they're pushing their maxilla forward and their mandible is not growing along suit. So there's a cascading effect of airway obstruction. And this is kind of what we talked about before. There's an obstruction, so then the lips open, the jaw's open to maximize that airway. And if your jaw is always open and acting like a sling, and you're not putting that tongue up on the roof of your mouth all of the time, you're putting pressure on that temporomandibular joint. And so it could eventually lead to having some TMJ issues if not remediated. The tongue position, because the tongue is low, the hard palate's narrowing, the dentition is changing, and sleep disorder breathing can be occurring because of all of that. Teeth grinding and clenching may be occurring. And again, that would lead into the temporomandibular disorder. So kind of the end of the line, or the major concern and what you're trying to avoid, is the CPAP machine and the TMJ issues. So what if we could work with these patients before we get to that point with therapy, or and prevent all of that? If that would be the hope. So nature versus nurture. So on the left side, this is what the face should look like. You can see that if I were to drop a string from the forehead down to the chin, it'd be pretty parallel line. But a mouth breather, if you just let it go, you don't do anything about it, you don't treat it at all with therapy or oral appliances, or any type of dental work, then that's what that same face would look like on the right. So you can see how the jaw is retruded, the mouth is open, the lips are fuller, the dark circles under the eyes. It's a quality of life issue, to be honest with you. He just doesn't look healthy on the right, does he? Daytime breathing patterns translate to nighttime patterns, which is why we do our best to work with our patients and make sure that they're doing the right thing during the day to obviously have some success, to have the success that they need at night to sleep and breathe well. So I've mentioned sleep disorder breathing, and I want to go through this real quickly. So it's restless sleep arousals, bedwetting, patients that are showing up with hyperactivity or focusing issues during the day. Patients, what also could lead to it was upper respiratory issues because they have chronic allergies. These patients typically will have nightmares and anxiety. But also kids usually show up with hyperactivity, and adults show up with more sleepy, like wanting to take naps during the day, or when there's sleep disorder breathing present. Aggression or anger, having a quick fuse, just kind of blowing your top really quickly instead of having that stop gait. Those are all signs and symptoms of possibly having some sleep disorder breathing concerns. And there's evidence to support that they say that 10% drop in IQ, or 10 points, I'm sorry, drop in IQ for kiddos that deal with sleep disorder breathing concerns. All right, so we've talked about breathing and the importance of nasal breathing, and now we're going to kind of switch gears and talk about posture. I'm actually going to let Andrea do this just so you have another voice to hear, and the reasons why we would go ahead and refer our patients, basically have a multidisciplinary approach and have body workers of some sort help our patients with their posture.
Okay, so this is the deep frontal line of fascia pictured here, and you'll see that the connection of the fascia through the body starts at the tongue and connects all the way down to the toes. So it truly really does affect the whole body. It's not just a tongue issue or a mouth issue. Some of the things that could be symptoms or signs that would also be seen possibly along with the tongue tie or oral, any kind of oral dysfunction, would be an immobile sternum or tension in the chest. That could cause issues with breathing patterns. It can cause cardiac and lung issues and rib problems possibly. That in turn, also that tightness through here, if there's tightness, if there's a tongue tie happening, there's tightness through here with all this musculature, then pulling that tightness into the chest, which then also you might see kind of winged scapula or shoulders that roll forward and then those scapula protrude outward. You might see patients also because of these fascia connections with forward head carriage posture, which we'll look at on the next slide. Base of skull tightness is an issue with those fascia connections. Tension on the front of the neck, which can also lead to swallowing issues and speech issues if the musculature through the front of the neck is tight because of a possible tongue tie. That tension also can translate to jaw development, causing the mandible to be retruded and possible TMJ issues to develop. That also can translate, all of this can translate all the way down the esophagus, causing hiatal hernia, reflux symptoms, heartburn, different symptoms like that. And then it can honestly translate throughout the whole body. You could see hip issues, leg issues. It really could run the gamut. So the whole body really is implicated, and it's important to have a multidisciplinary approach. And this is the forward head carriage posture and the effect of kind of that on your body, that for every degree your head's moving forward, it's adding weight that your body's having to carry, like the effect of additional weight. And then one other thing that we don't have a picture of that I just wanted to mention is symmetry, postural symmetry from side to side. Sometimes you might see patients whose head's a little crooked, torticollis possibly, sometimes shoulders that are not even. So one shoulder may be carried higher than the other, indicating tension on one side of the body that's causing asymmetry. So for optimal results for breathing and posture, those all need to be addressed as part of the therapeutic process.
Great. Thank you so much, Andrea. Okay, so the next would be, let's talk about jaws. So with jaw stability is so important. It's used for feeding, chewing, speech. It assists in that suck, swallow, breathe patterns associated with oral suckling and sucking. Vertical movements are for the munching. Lateral movements are for more complex rotary chewing, and there are structural changes that can result in that malocclusion, facial and bone structure development. So remember, muscle was going to win over bone, and so if the muscles are not acting appropriately, then bone structure will change. So tongue and jaw begin to separate their movements between 6 to 9 months of age. And there is much circumstantial evidence that jaws and faces do not grow to the same size that they used to, precisely because our foods are softer and we have more processed diets. So I always tell patients, what I think about is, if you think about a caveman and you think about their faces, they have these wide jaws, and they have these very, just a wide face. And then you think about our modern faces and how long and narrow our faces are. And a big piece to that could be our diet. So we like our chicken nuggets and macaroni and cheese and pizza, and it's affecting our jaw development and also affecting our dental arches because of that, as well as our airways. So this is basically what we talked about before. With Andrea, do you want to pop in and talk a little bit about breastfeeding?
I'm sure, yes. Breastfeeding is really key for optimal jaw development. Just as early as first minutes of life, when a baby latches on to nurse, that jaw is being engaged. Those muscles are starting to be developed right then. So just think, like you mentioned, changes in our diet. So even including babies with the formula diets and bottle feeding, which is necessary for some infants, they miss that opportunity to start that early jaw development. So they're a little behind the curve when it comes to jaw development and being able to develop healthy habits early on.
And I think the other piece is that when you are breastfeeding, you're munching, you're going in that vertical dimension, up and down, up and down. When you are bottle feeding, that's a different muscle. You're using different muscles, so and in a different way too. So it's more this, where you're drawing the milk in a more horizontal fashion is the best way to describe it. Because the cheeks are kind of sucking in and narrowing that whole facial structure.
Right. Those jaws are really working during breastfeeding. There's rocking going on, the compression of the tongue in the back part of the mouth to express the milk. But with the bottle, it's more these forward muscles, lips, and buccals are right here in the front of the cheeks that are working for bottle feeding.
Mm-hmm. We do get questions every once in a while from patients that say, what about sippy cups? Could that have affected my child's orofacial development? And the answer is absolutely. So sippy cups were designed by an engineer who did not want to get his carpets, splattered with any type of liquid on them. And they were not designed with a child's orofacial development in mind. So Andrea and I always recommend, when it comes to sippy cups, to find a sippy cup. If you need that, that's fine, but just find one where it's almost like a travel coffee mug, where you push a button and then you sip like a cup. That's much better for orofacial development than something in which is like where you have to suck from a almost like a nipple at the top of a sippy cup, which is kind of inducing that tongue thrust behavior. And just that sucking motion is affecting the palate and setting up a need for orthodontia later and changes of function. So again, here's kind of what happens over time. So you see this little baby with that retruded jaw. Again, if we just go untouched and we don't do anything about it, here's kind of what it could look like as an adult. And again, not a healthy look. So let's go to talk about the hard palate and why this is so important. If you were to take a patient and say, could you please open up your mouth and look up, and I just want to see the shape of your palate, what you don't want to see is something like a Gothic arch where it's V-shaped. You want to see a nice, big, wide U. That's what you're looking for. So kind of keep this picture, a mental picture in your head at all times, because this is what we're striving for with our patients. The patient on the left side is going to have problems with that patient's going to present possibly with the sleep disorder breathing concerns, with the temporomandibular joint concerns. The patient on the right, probably not so much. Okay, so the tongue, everybody just thinks the tongue is this one muscle, but it's not. It's actually, it's an organ, and it's like the rudder to the body. It's what you want to keep up and strong on the roof of your mouth because it provides stability. We've got several muscles in the tongue. So we actually have 4 extrinsic muscle pairs, and we have 4 intrinsic, sorry, can't speak, intrinsic muscle pairs of muscles that are helping shape and change the position of the tongue. So on the left is what your tongue should look like. So your tongue should be resting on the roof of your mouth at all times when you're at rest and while you're sleeping. The only time it really shouldn't be is when you're eating or when you're talking. And then on the right would be a patient that looks like that is presenting with a low tongue posture. And you can see what that is doing to the the pharyngeal wall and where it's resting, and how it changes the structures throughout. This is a picture of bracing. This is one of those habits that I was telling you about before that I often see in patients. If you ask a patient to stick out their tongue and you see that they have scalloping, we call it, along their tongue's basically taking the shape of the dentition that it's resting against. It's usually a sign that that patient is not resting their tongue up on the roof of their mouth. Most likely that patient has a low-lying tongue posture. So the correct tongue posture, if I were to give you, let's say, 3 orthodontic rubber bands, and I said, go ahead and put your tongue in the right place, I'd like to make sure that your tongue tip is by that first oval, right near the incisal of the papilla, and then the rest of your tongue is following suit along the roof of the mouth. So we, as orofacial myologists, would give exercises to our patients to work on that. Some of those types of exercises, just to kind of give you a taste of that, would be, again, tangible holds such as the rubber bands, and trying to learn how to swallow with your tongue in the proper position, all while obviously not trying to swallow those rubber bands. Trying to do tongue clicks, so they look like this. Tongue suction holds and pops, so suctioning your tongue up to the roof of your mouth as strongly as you can, and then popping it down. There's also something called mewing. That's basically the reverse of the way we teach it, but at the end of the day, it's the same. It's teaching you to get your tongue to rest up on the roof of your mouth and have good posture. So the way we teach it is to get your tongue tip up on the spot, like we did, like I was saying before, that spot being right where that oval is, and then suction your whole tongue up. The other way you could do it is to try to suction your whole tongue up to the, starting from the back of your mouth. So if I were to say the word sing, and elevate the posterior portion of your tongue, and then have the rest of your tongue follow suit onto the roof of your mouth, again, accomplishing the same goal of getting your tongue to rest up on that palate. Okay, let's switch to lips. So during our evaluations, we look and see how people are using their lips and what is their strength and coordination to use those lips well. Because we need our lips to round, to be able to suck from a straw, we need them to retract to smile, and we need to close to be able to keep food inside our mouth and maintain secretions. So if you have a child or an adult that often drools, my guess is that they have poor lip function. And here's what we were talking about before, that short upper lip and that full lower lip that is often seen with mouth breathers. And then the buccinator muscle is a major muscle, and that the buccinators are your cheek muscles, and they are helpful in sucking, swallowing, and especially I'll have Andrea talk about this a little bit more. I'm going to have her pop in because they're so important with babies to get that milk down safely.
Do you want me to pop in here?
Yeah.
Yeah, so they are really key for swallowing for babies and for just for optimal ability to feed, breastfeeding or bottle feeding, being able to extract the milk. That is the key muscle for suction. So babies are also born with what we call suck pads, or it's just additional fat in their cheeks. If they're full term or pretty close to full term, you'd be able to feel that in there, which helps complete the seal for breastfeeding so that they're able to maintain a suction and feed properly.
Great, thanks. Okay, and so let's switch gears a little bit. We're going to talk about tongue ties because I know we only have 15 minutes left. So I know I need to run through this, but it's super important. So reasons why people would have an open mouth posture, like we talked about before, would be, do they have a tongue tie, which is basically pulling down their tongue, or do they have, like I said, the tonsils, adenoids, or some sort of upper respiratory concern? So with tongue ties, they're unusually short, thick, or tight band of tissue that goes from the floor of the mouth to that tongue tip, and it's tethers on the, it's so tethered that it's affecting the function of the tongue. So someone who is tongue-tied might have difficulty sticking out his or her tongue, but that's not the most important indicator of a tongue tie by any means. And I think sometimes there's a lot of dentists out there and pediatricians who feel like that's the tall tale sign, and there's just so much more to it. So we're going to talk about that because you could have somebody who's able to stick out their tongue pretty well, but when it comes to doing some other exercises, such as trying to get your tongue to reach the back teeth to clear food, they're not able to do that. Or be able to cup their tongue the right way to be able to speak well or to swallow well. Again, those all, or to rest your tongue on the roof of your mouth, all of that can be affected by even a mild tongue tie. This is an easy one to spot. This is a easy one because you can obviously see how the tie is going straight from the floor of the mouth right to the tongue tip. Most people would be able to see that, even untrained professionals, and say, wow, that doesn't look quite right. But we're going to kind of go through a little bit more in terms of the range of tongue ties, because it's the ones that are like, is that really a problem or not? That's the issue, and they need to be looked at to make sure that it's not the culprit as for some inappropriate patterns of orofacial development. So the lingual frenulum affects the movement of the tongue, and it occurs actually in utero. The tissue basically just never divided the way it should have, and it just cells kind of stayed put and didn't divide, and tissue remained. So that residual tissue may restrain the movements of the tongue. So it's going to influence food preferences and meal behaviors, which is why Andrea and I have such an interest in working with patients that are having some food jags, because maybe it's because their oral function is not quite right. There's maybe more to it, why they're not preferring to eat certain foods. And it's going to include why patients may be open mouth chewing and maybe gagging on meals, or coughing often. So those class 3 and class 4 tongue ties are the ones that are the biggest culprits in terms of pocketing some debris and causing those dental cavities. And so I want to go through, I will show you kind of the different classification systems, but I just wanted you to kind of keep seeing this, to drive home the point that there's so much evidence out there and so much research that's suggesting that that little string, that tie, that frenulum, that tethered oral tissue is a known factor in altering that orofacial growth and impacting the maxilla and the, the hard palate because of the low placement of the tongue. And basically there's no pressure being put on that palate, so the dental arch is narrow. And when you look inside, you see, like I said, that Gothic arch, you see that vaulted palate, that bubble palate, and mouth breathing often during sleep. So here's a picture of a restricted frenulum. That again, I know that we were looking at, on the other side, we were looking at it from the tongue tip perspective, but I want you to see kind of what it can look like from the floor of the mouth perspective. It almost looks like an Eiffel Tower right there. And it'll often have implications because you'll see that these central incisors on the mandible will rotate a little bit. They will, because of the force of the restriction. And you may get a little diastema right there. And let's kind of move on. And it can also affect swallowing. So there's kind of 4 phases to swallowing. The first phase is when we put the food or the drinks straight to our lips and how we kind of handle that. And then manipulate the food and the drink from there. And then the next one is how we move it within our mouth. The next phase is how we move it within our pharynx. And then the next phase is how we handle it from in the esophagus. So I would tell you that as orofacial myologists, we definitely spend a great deal of time on the oral prep and oral transit phase of the swallow. This is Dr. Zaghi. He is very well known in the field of tongue ties, and he runs something called the Breathe Institute. He's an ear, nose, and throat doctor. And so if you want to dig more into tongue ties, learning more about them, I would highly recommend looking him up and reading his research and just learning more about him. He's just really on the forefront right now on tongue tie research. And he wrote a book along with, and Dr. Lin, I'm sorry, I meant to mention him. So Dr. Lin wrote a book that's very, very popular called The Dental Diet, and speaks a lot more in detail of many things that we've spoken about today. So it's a great book to grab. And both are just highly intelligent and pioneers in this field. So Dr. Zaghi created something called the tongue range of motion ratio. So what he does is he has created a protocol in which we will measure a patient's maximum opening, we'll measure how well that tongue tip goes up, and what is the distance between the tongue tip to the incisor papilla, and then what we also measure how wide a patient can open up with their tongue suctioned up to the roof of their mouth. So, and we're looking at the ratios between all of that. And we use something like this quick tongue tie assessment tool to do so. We also look at tongue ties from another way, and that is to lift the tongue up like this, as you can see on the left side. And then we're trying to measure the free tongue length. So we're looking at where the tongue tie inserts on the tongue all the way to the tip of the tongue. And that is Kotlow's classification system. So he would tell you that if there's 12 to 16 millimeters between where the tongue tie inserts to the tongue tip, then that's considered mild. If it's basically right up to the tongue tip, it's class 4. Those are the very, very obvious ones. You can look up Kotlow. You can Google that if you want. This is Kotlow's evaluation of ankyloglossia, and kind of have that to help you decipher where he is on that. And then he also has one for lips. So you can look at the class 1 being that the frenulum really isn't affecting any, that tethered oral tissue isn't of any concern, all the way to class 4 where that frenulum is going through, like in between the teeth and all the way to the incisors of papilla and causing that diastema. So it's really important, and I'm going to have Andrea just pop in here for like 1 minute and just talk to you a little bit about why it's important to make sure you have your ducks in a row before you just go ahead and do a tongue tie release.
Mm-hmm. So this particular statement is regarding infants, but it really is across the lifespan. It's important to have pre-therapy before a tongue tie release is performed, because the body wants to heal back to the way it was. If there's tension in other areas of the body that haven't been addressed, and if muscle function and muscle strength haven't been maximized prior to that, the outcomes just aren't going to be as optimal as you would like for them to be. There's going to be a higher chance of reattachment or scar tissue forming and a reduced range of motion that we're looking for.
Okay, so just to talk a little bit about swallowing, we want to get the teeth together just briefly for the swallow. They just tap real quickly, but we don't want the tongue to thrust so forward that's affecting dentition. You basically want that tongue tip to go on that incisive papilla, which we talked about before. Watch your patients, watch them drink some water in your office. Watch to see, are they going like this and greeting that cup with their tongue? It's never a good sign. They possibly are tongue thrusting. Watch them drink that water and have them go like this. So just open their mouth wide and smile while they're drinking that water. If you see the tongue come thrusting through as they are drinking, concerned that there may be a tongue thrust pattern of their swallow. So here's some pictures of what that all may look like. And these are signs and symptoms of dysphagia, which is basically an abnormal swallowing in children. And then I have another one with adults. So I'm just going to give you a second to look at all of that. But they're basically going to be those kiddos that are stuffing food in their mouth or needing to taste food with drink often. They're going to be those ones that are spitting out their food or drooling a lot, having just difficulty with chewing in general. Adults are going to have that poor oral management as well. They're going to complain of maybe having some fullness in their neck, or it's difficult swallowing, or gurgly, coughing when they're swallowing. Any of those are probably not great signs, or are concerning. All those are concerning signs that the swallowing is not controlled. So here's just the connection between the mandible and that lingual isolation and dissociation. So you basically want the lips, tongue, jaw, they all have their own jobs, and they don't need their friends to help them. So in other words, when you swallow, you don't need your lips to help you swallow. You should be able to swallow just like this. You shouldn't need to go struggle to be able to swallow appropriately. Speech can be affected, but with especially with our tongue-tied kiddos. So T, D, N, and L, those are all sounds that are sounds that you need to lift your tongue tip for. And if you're not doing that, then it's going to come out like T, D, N, and L, which affects your intelligibility. S and Z, sound, judge, R, those are all affected when the posterior tongue is not lifting appropriately. So I want you to look at your patients as soon as you say hello, and I want you to observe their tongue, their lips, their jaw, their face during conversation. Look at their oral habits. Look at how they rest their jaw and their lips. Look at how they're managing their saliva. Look at how they're breathing. Look at how, ask them those sleep disorder breathing questions. Ask them about any habits. If you see any of those concerns, that's the time to probably make a referral to one of us to be able to help and see what we can do from a therapy standpoint. So what age should therapy begin? Like we said, it's throughout the lifespan. So whenever you have any concerns, you can refer to us and we'll help them at any age. And myofunctional therapy, that our goal is to kind of eliminate these habits, get these lips closed, have people breathing normally, have good dental resting, have a good resting posture to help dental development, correct tongue placement, help them swallow appropriately, speak appropriately, improve their posture, and then again, their speech and their swallowing techniques. So is treatment successful? It really is. They just have to do the therapy. So the only time we really can't do it is when there's a palatal expander in the way, because then we couldn't work on getting the tongue resting on the roof of the mouth. And they can be, but other than that, we really typically are there to help. So here's just a quick picture of a success was they did speech language pathology. They did myofunctional therapy, and they had a tongue tie release. So those were just the two factors in the change in such a short amount of time. And there's such a, he looks on that left side. If you have more interest in this, go ahead and join this study group if you are a practitioner. This oromyofunctional study group is a wealth of information, and it's very widely well known and respected. And this is a video we don't have time to answer or to look at. Any other questions?
I have a question.
Yeah.
Okay. Do you, especially now with all the stuff with COVID, do you ever do any remote office visits? Are you seeing people through Zoom?
Yes, we are. That's exactly what we're doing. We're doing teletherapy.
You're lucky. Texas doesn't think that's legal for us. We can't do teledentistry.
And so how would people schedule an appointment? Can you put a contact information on here in the chat area?
I can. So I'm going to share my screen again, go back to my presentation. I was just trying to click out really fast because I wanted to make sure that, let's see if I can get it to move. It's not moving. So yeah, there's contact info right there. Our office number's there. Our emails are right there. Our website's there. So you can contact us that way.
And what does a typical appointment, the length of time and the cost?
No, that's a good question. So the first appointment for the evaluation, we spend a good amount of time with our patients, typically about 90 minutes, so an hour and a half. And because we're taking such a thorough history, as well as watching all these factors that we talked about today. So that, and then we write an extensive report and send that report to the patient themselves, as well as to any of the practitioners that are involved in their circle of care. That's $250. Therapy itself is typically 30 minutes, typically once a week. And that's $65 for a half-hour session.
Okay, great. And then are there requirements for someone who wants to learn, actually go through training for myofunctional therapy? Do you have to be a speech therapist? Do you have to be a dental hygienist? What are the prerequisites?
Yes, so exactly what you just said. So according to the there are several bodies, governing bodies that are training, but to become a certified orofacial myologist, you must be either a registered dental hygienist or a speech language pathologist.
Okay, thank you.
Mhm.
All right, anybody else have any questions?
Nope. Thank you so much, Sue and Andrea, for this lovely, lovely presentation. Thank you so much.
You're very welcome. It's our
Thank
pleasure.
you for inviting us.
Okay, great job. We're going to go ahead and, oh, somebody asked a question here.
Sure.
Can doing it by Zoom, can that work for a 3-year-old?
Well, I'll be honest, I think it's a little hard with the 3-year-old, but what we could do is if the parent was willing to take, like, you know, be patient with us, I guess is what I'm saying, and take instruction well, it would be more, I will be honest with you, it will be more like we are telling the parent what to do, and the parent's going to have to execute it throughout the week for us to see some major changes. Because as we all know, an attention span of a 3-year-old is they're not going to hang in there for a good hour and a half.
Yeah.
And they probably won't even hang out there for 30 minutes. So what we really need is to use the parents' input and then help them through that.
And I
Okay.
will say, though, I do have a few 3-year-olds that I'm working with right now, and it's been very successful. So it's very patient specific and needs driven. So it really depends on the patient and the family situation.
We've definitely gotten more savvy and come up with more fun games to play with 3-year-olds during this COVID-19 crisis.
Yeah. Okay, well, what we're going to do is we're going to finish the recording for tonight so that this can be up by this evening or tomorrow at the very latest. And I'm going to encourage everybody to share it with as many people as possible because it plays a very important role in biological dentistry. And so the information just needs to get out there. And I want to thank you guys again for Zooming with us.
Oh, we really thank you very much. The pleasure is all ours, and we are honored that you asked